Is this life-threatening? Hi everyone, Dr. X here. And today we're walking through dizziness exactly as the flowchart shows. And to make this real, let's start with a case. A 64-year-old man walks into the ER holding the wall, saying, "The room is spinning. I can't stay steady." His blood pressure is high, he looks anxious, and the script tells us the very first question: is this life-threatening? We look for the big five. Focal neurological deficit, severe truncal ataxia where the patient literally cannot walk, vertical or direction-changing nystagmus, sudden unilateral hearing loss, or cardiogenic symptoms like chest pain, palpitations, or syncope. If any of these are present, the script is absolutely clear. Central suspected, get MRI or CT immediately, and stop the algorithm. No maneuvers, no bedside tests, imaging now. If none of those red flags exist, the script moves us smoothly to the second branch of the chart.
What is the sensation? The script divides dizziness into four very different experiences. Spinning, which is true vertigo. Feeling faint, which is near syncope. Imbalance when walking, disequilibrium. And vague lightheadedness, which is nonspecific. This step matters because patients say, dizzy, for everything, but the script forces us to classify it correctly before we do anything else.
Near syncope branch. If the sensation is feeling faint, the script says near syncope. Check vitals, check ECG, check orthostatic blood pressure. Then think dehydration, medications, arrhythmia, blood loss, and correct the cause. If nothing abnormal is found and the patient is stable, the script clearly ends this branch. No further dizziness algorithm needed here. True vertigo branch. Now the real diagnostic work begins. If the patient reports a spinning sensation, the script sends us directly into true vertigo.
Triggered or spontaneous. This is the next major branch of the script. Triggered vertigo, especially with head movement, strongly suggests BPPV. The script is very direct here. Movement provoked, brief episodes right pointing arrow think BPPV. But if the vertigo is spontaneous, appearing without position change, the script tells us to move straight to duration.
Duration of episodes. This is one of the most important timelines in the entire script. Seconds right pointing arrow BPPV. Minutes to hours right pointing arrow Meniere disease or vestibular migraine. But the script bolds this next point. Continuous vertigo lasting days can only be vestibular neuritis or a central cause like cerebellar stroke. This is why the next step of the script is the centerpiece.
Hints exam. The chart puts hints right in the center of acute continuous vertigo, and for good reason. It distinguishes peripheral from central far better than early MRI.
Hints interpretation. The script lays out the three components very cleanly. Head impulse test. If it's abnormal, it's peripheral. Nystagmus. If it's unidirectional, it's peripheral. Skew. If there is no vertical skew, it's peripheral. But even one central sign, normal head impulse, direction-changing nystagmus, or skew deviation, means MRI immediately. The script is strict here. No exceptions. Cerebellar strokes hide behind normal vitals and normal CTs all the time, so the script forces you to treat central signs seriously.
For peripheral summary, now the script moves into the short peripheral list. BPPV is triggered by movement and lasts seconds, with a positive Dix-Hallpike and treated with an Epley maneuver. Vestibular neuritis is acute continuous vertigo lasting days without hearing loss. Labyrinthitis is the same presentation but with hearing loss. Meniere disease causes vertigo lasting hours, often with tinnitus and fluctuating hearing loss. And vestibular migraine can mimic everything, with or without headache or aura.
For central summary, the script finishes with a concise list of dangerous central causes: cerebellar stroke, brainstem ischemia, MS relapse, and tumor or hemorrhage. All require MRI with diffusion and CTA of the posterior circulation. If the patient fits this branch, there are no bedside maneuvers and no watch and wait approach. It's straight to imaging, and that's the entire dizziness algorithm exactly as written in the script, from life-threatening red flags all the way down to peripheral versus central vertigo. This structure lets you move fast, stay safe, and avoid missing the central catastrophes that hide behind the word dizzy. See you in the next video.